So for those of you guys watching this quick little demo treatment for my patient, this patient has had an abdominal flap scar, as you can visualize here. If you want to come close and just visualize the length of it. So it does go from post ASIS, just above the bone of tubercular, comes right across. It does grab onto the other side here. So this patient had a double mastectomy breast reconstruction that the surgeons used an abdominal flap to rebuild the breast tissue. And this is the leftover scar from that procedure. The patient felt lots of restriction, lots of adhesions. There was some pain symptomatology associated with lack of functional movement. So we have been treating this patient for quite a while, through a series of treatments now with ART, active release technique, as well as Graston technique. So we start with a GT4 with emollient. Patient's comfortable. So in a static position, we just ensure that there's enough emollient across that flap. For comfort's sake, we need to make sure that there's not too much in the way of friction into the skin. So you can see, if you pan out a little bit, there's an itching. Patient is in a supine position, knees flexed over top of a Bosu ball. So this is going to allow the patient to actively flex her spine, contract, shorten the abdominal fascia, shorten the erectus abdominis, all the associated tissues, and that'll allow us to go into a flexion extension dynamic movement. Okay, good. So whenever you're ready, come on up. So right there, I'm going to pin and go ahead. Hold it down. Good. Again. Come on. And down. Good. Again. And down. Come on up. So you can see when the patient elongates from a shortened position to an extended position, we hold, in this case GT4, hold the instrument just slightly proximal and to the scar tissue, and then as they eccentrically unload, the tissue slides underneath the instrument. We can sometimes assist it with grabbing the tissue to make sure that there's a nice contact. There's going to be a different feel going from this direction because the tissues do slide that way. So therapeutically and clinically, it's always better to go against the grain of the fiber direction. Come on up, please. One more time, and go. Right across the tissue. So this scar is stable. It's long since the sutures have been removed, so it's stable. What we're treating is the underlying restriction and adhesions that are built in around this tissue line across the abdominal. So I would repeat that. Sometimes I might even get into a static position where we use a secondary GT instrument and we just get underneath, semi-sit up just a little bit, block. And this is protocols from M1 where we block the scar. I can reverse it, block, and use that scooping technique to get underneath the scar. And I would do that all the way down right to the other side. Okay?